Hi, this is Suzanne Gregory, and this is Breast Cancer Through the Eyes of the Patient and the Provider. The National Cancer Institute Surveillance, Epidemiology, and End Results Program, or SEER, calls breast cancer one of the most common cancers in the United States, representing over 15% of new cancer diagnoses. 3.9 million women are living with the disease in the year 2020, and 1 in 7.7 of us women will develop breast cancer over some point in time in our life. Although the 5-year survival rate currently is over 90%, which was up from 80% in the mid-1980s, it's estimated that in the year 2023, there will be 43,000 deaths from breast cancer. I had the opportunity to interview a patient, Jane Doe, who completed treatment for breast cancer, as well as a physician, Dr. Diane Buchbarger, who regularly treats breast cancer. Being diagnosed with breast cancer is very difficult despite all of the progress made in screening and treatment, and many women fear a potential diagnosis. Through these interviews, I was most surprised to learn that for many breast cancer patients, the most difficult part of breast cancer isn't receiving the diagnosis. Rather, it is living through treatment and beyond. The most recent final recommendation for breast cancer screening was issued in 2016 from the U.S. Preventive Services Task Force, and the official recommendation is for all women ages 50 to 74 to have a mammogram screening every 2 years. Women ages 40 to 49 can opt to start regular screening before age 50. Although screening inherently comes with risks for overdiagnosis, which leads to overtreatment, false positive results, the need for unnecessary or invasive procedures, which could cause anxiety and also exposure to radiation. But through patient and physician input, they can opt to start mammogram screening as early as age 40. Dr. Buchbarger, who is a medical oncologist and has been treating breast cancer for years. When I asked her what the biggest issue is during screening and diagnosis, she states that it's really essentially the time that it takes to get access to care, and points at the time it takes to get from a screening mammogram to the first appointment with an oncologist. There can be a week or more between every single step, and many patients have to undergo a screening mammogram, a diagnostic mammogram, an ultrasound, and a biopsy, and get results of each before they can schedule their very first appointment with the oncologist after all results are finalized. She really also feels that electronic health records and the availability of those results online have increased the anxiety that women experience while waiting to see a physician and begin talking about the treatment plan. Jane Doe, who I also interviewed, she received her diagnosis of breast cancer when she was 46 as a result of a screening mammogram that she described as being overdue. Jane received a prescription from her PCP for a mammogram in 2020. And, it was the pandemic. There wasn't a lot of appointments available. But even once those appointments opened up later on in 2020, she still put off scheduling making the appointment just because she felt like it was going to be a lot of hassle to make the appointment and go in for the mammogram, and it was going to take a lot of time. So she did finally schedule it in 2022 after talking with a good friend who was going through treatment for breast cancer. She actually tells me that she was pleasantly surprised that the mammogram scheduling and the time it took to take the test didn't take very long at all. After her mammogram, she did have to get an additional diagnostic mammogram, ultrasound, and biopsy. She was unfortunately diagnosed with breast cancer. And although she talked with me about her emotions at the time as being a roller coaster, she estimated that testing and diagnosis only took about 2 weeks total, which she perceived as being very quick. Now you can see here I have listed, although not an all-encompassing list, some examples of risk factors or protective factors that may make it more likely or less likely for you to be diagnosed with breast cancer. Jane herself had several personal factors that either increased or decreased her personal risk for breast cancer. Some of the factors that increased her risk for breast cancer were her race, being Caucasian, being older at the birth of her first child, using alcohol moderately, and having a mother with a diagnosis of breast cancer, as well as having breast tissue that was considered to be dense. Her personal factors that decreased her risk of breast cancer were her weight. She was of normal weight. She was a non-smoker, and she had a negative status for the BRCA gene mutation that can be associated with a higher incidence of cancer and are present in about 5 to 10% of cases, according to the National Cancer Institute. Now, Jane was also employed as a nurse and had a history of active duty military service that may have exposed her to environmental factors that could have increased her risk for breast cancer, although no current exposures were currently known to her. Now, going from the news of breast cancer diagnosis to treatment, once you're diagnosed, treatment planning begins. First, they may have to do some further testing to really accurately determine the cancer stage and the likely response to treatment. Those tests can include MRI imaging to evaluate if cancer cells are located in other parts of the body, and genetic testing. The treatment selected is really impacted by the stage and the grade of the cancer and the molecular profile, as well as the menopause status of the patient. Treatment can include combination of chemotherapy, surgery, radiation, and hormone therapy, and the order in which those treatments are given also really depends on the size and the other characteristics of the tumor. Of course, with treatment, that can lead to side effects. Now, Dr. Butch Barker, who works at a single physician site, she has to treat any type of cancer that hits the door, but tells me that she didn't originally seek to specialize in breast cancer specifically, but tells me that it chose her. She enjoys treating different types of cancer, but quickly became the physician that all breast cancer cases were referred to because she was the only female physician in the department at the time. So, as far as treating many different types of cancer, Dr. Butch Barker, like many other medical oncologists, uses the best-in-class treatment guidelines that are set by the National Comprehensive Cancer Network, which outlines the choice first, second, and third line cancer treatments to follow as a standard treatment pathway. When I talked to Dr. Butch Barker about delays in treatment due to insurance or any other factors, she really doesn't feel like that she sees a lot of delays due to insurance approval. As long as she's following those standardized treatment pathways, she thinks that the approvals for surgery, radiation, or chemo treatment plans really runs pretty smoothly. Now, Jane's treatment plan was a lumpectomy followed by chemotherapy because she had an early 1.6 centimeter mass found in her left breast, which was estrogen and progesterone receptor positive, as well as HER2 positive. These tumor markers tend to indicate that her cancer specifically would respond better to hormone therapy and treatment with Herceptin, as opposed to triple negative breast cancer that would be in general more aggressive and have poor survival. Unfortunately, with further testing, Jane learned she had more tumors, which complicated the plan. An MRI found an additional 1.4 centimeter mass in front of the original mass, and also another spot that was determined to be ductal carcinoma in situ. Both were picked up by an MRI, but were not visible on the original mammograms that she had. The sum size of the masses made changing her treatment plan necessary, and Jane had to go through neoadjuvant chemotherapy, which is a chemotherapy to shrink the tumor prior to her surgery. So she got several cycles of 4 different chemotherapy drugs and was to have surgery after chemotherapy was complete. Her tumors responded very well to chemo and shrank all the way to 0.4 centimeters, after which she opted to have a left mastectomy. Her and her surgeon reviewed this treatment plan carefully, and it was selected instead of bilateral mastectomy since she was BRCA negative, and she and her surgeon felt that she wouldn't have any additional risk for recurrence by leaving her left breast. Jane told me she was overwhelmed by the decision she had to make about the surgical reconstruction of her breast. Many women undergo reconstruction after the mastectomy to restore their body image, and they have potential options of having breast implants or a muscle and skin flap. Now, Jane learned that implant, if she got a breast implant, it could have potential complications and would need replaced periodically throughout her life. And once she learned that the implant would need to be put under her muscle, and her muscle and tissue would have to be stretched over time, which would be long and painful, she decided to go with a flap, even though she knew that the surgery could last for 10 hours or more. Now, the cost of cancer treatment really comes in many different forms. They can be in financial, physical, mental, emotional, health, and more. In Jane's case, she felt that she was really lucky to have fewer side effects than many of the women that she saw while she was visiting the cancer center for treatment. Jane herself had hair loss, diarrhea, fatigue during chemotherapy, and after every cancer infusion, she would have a metal taste in her mouth for 5 days. She also had hot flashes and symptoms of menopause while in treatment for cancer. Side effects actually can be a lot more intense than that and can include low cell counts, nausea, vomiting, endometrial cancer, and even thromboembolic conditions. Jane was able to keep working throughout her cancer treatment because she has a job with a flexible work arrangement, and she had the ability to work from home and only needed off work briefly for surgical recovery. In Dr. Butch Barker's practice, many patients are not as fortunate. She really felt like the biggest problems anyone faces are financial. She had told me that even people with really good paying careers like lawyers may run into financial difficulties if they don't anticipate the time they need to take off for treatment. Short-term disability might be needed before someone has been in their job long enough to qualify, and often it only pays a fraction of the salary even when they do qualify. This can turn into loss of a job, loss of health insurance. Dr. Butch Barker also talked about childcare, how much of a challenge that could be. You know, they have to plan who's going to pick up the kids, who's going to take them to swim practice. She talked about other key issues faced by people with breast cancer involving relationships with others. They may resent being treated like a person with cancer or have intimacy issues because they don't have a desire for sexual contact. Perhaps one of the most difficult issues is facing the future. For Dr. Butch Barker, she sees patients having trouble planning, say, a kitchen renovation or an event because it reminds them that they might not ever get to see it. For Jane, who's now in remission, she felt that it was actually more difficult dealing with her emotions now than it was dealing with them while she was going through treatment for active cancer. Cancer can come back, and Jane fears that it'll return in her brain or another location. She is in a clinical study right now to participate in on the role of physical activity in cancer recovery, and finds support from her peers in that study very valuable, but still struggles with her emotions, and reached out to engage a counselor in the week that I interviewed her, saying, I need more tools in my toolbox to help me deal with this. Even with a really flexible job, supportive providers, friends, and family support, Jane admits that she struggled with this stage of her cancer journey. Overall, cancer survival rates have increased over the last few decades due to several factors, including increased mammogram screening, genotyping to detect genes that increase risk, and targeted therapy to address hormone or HER2-positive cancers. Despite more women surviving after breast cancer treatment, there are a number of treatment-related side effects as well as emotional and financial impacts that can take a toll long after the cancer is gone. Holistic support is critical in this population, even after treatment has been completed. Thank you.